Hello, and welcome to today's webinar, Driving Consult Efficiency, How a Premier Healthcare Organization and its Partners Leverage Integrated Digital Pathology, hosted by Dark Daily and sponsored by Grundium. My name is Ashley Harris, Manager of Operations at the Dark Intelligence Group, here with Amanda Curtis, Director of Marketing and Sales. If you are not familiar with Dark Daily, it's one of several clinical laboratory and diagnostics news and business information resources from the Dark Intelligence Group. You can always learn more about business critical issues by reading the Dark Report, the industry's preeminent source of business intelligence. A reminder that this call is being recorded for playback on demand. Attendees are muted, but you can message us at any time with questions, comments, or needs. Just use the questions box of your GoToWebinar control panel. I'll be monitoring the chat for today's call, and we will leave some dedicated time for a live Q&A at the end, so be sure to stay for the entire presentation. I would like to take a moment to introduce our speakers today. Dr. Anil Parwani is a professor of pathology and biomedical informatics at The Ohio State University. He serves at the Donald A. Sinhauser Chair of the Department of Pathology and the Chief of Pathology Services for the health system. His research is focused on diagnostic and prognostic markers in bladder, prostate, and renal cell carcinoma. He has expertise in surgical pathology and pathology informatics, including biobanking, whole slide imaging, digital imaging, telepathology, image analysis, artificial intelligence, and lab automation. Dr. Parwani has authored over 400 peer-reviewed articles in major scientific journals and several books and book chapters. He is the editor-in-chief of Diagnostic Pathology and co-editor of the Journal of Pathology Informatics. Scott Hammond is Senior Systems Consultant and a key member of the Digital Pathology Program at the OSU Wexner Medical Center, OSU CCC James. OSU's nationally recognized division processes over 2,400 slides daily and maintains one of the world's largest whole slide imaging archives, over 4.7 million slides across 500,000 cases. Scott oversees infrastructure, including digitization, workflow implementation, consultations, and quality assurance. He supports remote diagnostics, real-time collaboration, teaching, and research, and leads clinical research efforts for the FDA platform and device validations. His administrative leadership has been instrumental in OSU's pioneering use of digital pathology for primary diagnoses since 2018, helping advance fast, accurate, and scalable pathology services. And Melinda Schumacher, MD, is an associate professor clinical in the community pathology branch. Dr. Schumacher earned her MD in 1982 from Wright State University School of Medicine in Dayton, Ohio. She began her residency in anatomic and clinical pathology at Kettering Medical Center in Kettering, Ohio, subsequently completing it at the Ohio State University in 1987. She continued and completed her training at Ohio State with a fellowship in medical microbiology in 1988. Dr. Schumacher is a community general pathologist with a focus in GI pathology and an interest in dermatopathology. She is a proponent of digital imaging in support of enhanced workflow and turnaround times, plus ease of consultation with continual learning and enhancement of pathologists' diagnostic skills. Welcome to our speakers today. We'll begin by going over what our audience will learn during today's webinar. Today, attendees will learn how to identify the challenges presented for pathology consultations and second opinions due to shortages of qualified pathologists and lab staff, assess how digital pathology tools address skills and staff shortages, and predict common IT challenges with implementing new digital pathology tools. Dr. Parwani, at this time, I will hand it over to you and I will catch up with everyone at the end of the program. You may take it from here.
Thank you, everyone. Thank you so much for attending this webinar. We hope this will be useful for you as we will try to provide you with some solutions that enable expert pathologists and general pathologists to connect with one another for better patient care. Pathology, as a pathologist, we are aiming to provide gold standard in diagnosis. All treatment protocols are based on diagnosis and associated data elements, which are provided by the pathologist. Have anything from a patient with lung cancer all the way to a patient with ulcerative colitis. And we're in an era of precision pathology. So the right diagnosis matter for the patient, because our goal is to give the best diagnosis in a timely manner to all patients. It doesn't matter where they are in our system. Next slide, please. So how is digital pathology helping pathologists and patients? There is a decline in the number of available pathologists. There are at the moment 700 jobs open for pathologists in the US, and globally there's a shortage of pathologists. Pathologists have increased workloads, fewer trainees are going into pathology, and this workload is also increasing because of the complexity of the diagnoses. So remote consults are super helpful because it enables me, who I practice GU pathology, I'm able to connect to a dermatopathologist. I can connect with Dr. Chung and show her a difficult penile lesion and show this in real time using a digital image. So today we're going to show you some solutions that we have implemented at our university and our medical center, which allows us to share diagnosis with one another rapidly. Last week, Dr. Schumacher sent me a difficult kidney case to review, and I was able to consult with her in real time. So easy access to subspecialties. Next slide, please. So again, my point, we're not going to spend a lot of time going into all the benefits of digital pathology. We're going to focus on very specifically teleconsultation, remote diagnoses, and the ability to do that in today with a solution which can be easily accessible and it's broadly available. So next slide, please. So we're going to talk about whole slide imaging, which is the solution that we are using at Ohio State and Worcester Community College. But it's a given for many, many decades. Significant research has been done and studies have demonstrated that these images that you are able to get from a whole slide imaging machine or a scanner, they are a commodity now. So it's not a question whether we can use these for diagnostic purposes anymore. Several FDA trials have been done on other devices, and many, many research studies and clinical studies have really demonstrated that these images are not non-inferior to a glass slide, or in some cases, it's even better. Next slide, please. So just a brief word about digital pathology at Ohio State. We started in 2016, and we started by implementing primary diagnosis, scanners and digitized images for primary diagnosis. We integrated with a new LIS system, and then we've continued to see an increased adoption, especially during COVID. And I would say greater than 95% of our pathologists are completely digital at the main campus, and many pathologists in our community division are starting to use digital images in their daily workflows. And it's for a number of reasons. So today we're going to focus on the use of whole slide images for consultation and second review and second opinion. We are not going to talk about AI specifically, but one of the advantages of having a digital image is you can do more than just a diagnosis on it. You can find predictive markers, you can use AI algorithms and so on. So that's not the focus of today's talk. Next slide, please. So we're going to focus on teleconsultation, and this could be a formal or informal diagnostic opinion, which is provided to the primary pathologist by an expert pathologist. It could be within your practice, it could be outside your practice, it could be domestic or international. Especially considerations are for solo pathologists who are practicing in a remote location, and they come across a challenging case that is rare and they have not seen it frequently, so they turn to a second opinion. So Overall, these is not just confined to specialty areas like neuropath or dermpath. It could be areas that you're comfortable with, but you don't see that type of sarcoma rarely, often. So again, what for teleconsultation is a second opinion. It's not equivalent to providing a primary diagnosis using an FDA-approved scanner. So I wanted to separate those two notions. Next slide, please. So those consults again can be from multiple sources. We could create a hub and spoke model within our hospital network. We are an academic hospital in Columbus, but we have several hospitals that our pathologists travel to. The one today we're going to focus on is Worcester Community Hospital, which is about 90 minutes away from the main campus. So it's not feasible to send consults on the fly every day because there's limited couriers and travel, but we have other hospitals which are even further away. So within the main campus, we have about 40 specialists who specialize in all anatomical pathology areas. We also have molecular pathologists. We also have hematopathologists. So it's easy to connect to a main hospital academic pathologist or a subspecialist pathologist. Next slide, please. So what are the barriers? So today our goal is to also outline some of the solutions, but also try to give you a perspective on how to overcome the barriers. So what are some of the barriers? Next slide. So challenges with glass slide, right? Physical slides have to be shipped. They could get lost. They can get broken. They can go to a wrong office. They might be sitting on a pathologist's desk while that pathologist is on a vacation. Metadata transfer, information about the patient, the demographics, the radiology reports, and it could also be communications barrier. The consultant alters immunostains. They might go to the wrong hospital. They might not be scanned or stained appropriately. So those are all what go under the communication barriers. Next slide. So these are some of the things that are traditional consultation. It's painful, often unreliable, and takes a long time. If you want a specific consultant, it might take 2 to 3 weeks. That's the glass slide world. Let's go to the next slide. So in order to provide this opportunity, this just shows you roughly the typical time frames for external expert pathology consults. Even a hospital like Worcester, who's part of our network, we can see significant delays of shipping, sending it by courier, accessioning, expert review, testing, which might be needed, like molecular pathology analysis. So it's not uncommon to have a turnaround time of ranging from 5 to 21 days often, but on average, 7 to 10 days is not out of the ordinary. So if you're going to build a solution, the results have to be fast. They have to be instantaneous. Next slide, please. So the other issues with sending images, if you're just going to have a camera on your microscope, or you're going to use a off-site scanner, where the scanned images are scanned, but they're not in the right image format. You want to be able to use the right image format. You want to be able to use a system which is image format agnostic, or provides its own images which are compatible with any system out there. You don't have to worry about how are you going to view this software. So if I can have the image scanned, but I need a proprietary image viewer. So that's another issue. You also don't want to physically send the patient metadata. It's tedious, it's time consuming, and it can cause errors in the system. So next slide, please. So you want to be able to send images of the right format, but also the image quality must be great. Pathologists will not look at a digital image if it's pixelated, if it takes too long to load. So again, the system that you choose finally must overcome these barriers. It's easy to use, it's reliable, and image quality is superb. It should not be inferior to the glass slide. If anything, it should be superior. Next slide, please. So one of the ways to think about is, if I had to buy a scanner or a system out there, what are things I'm looking for? I'm looking for streamlined digital image transfers. I'm looking for enhanced metadata accuracy. I want to minimize handling errors. It should be so good and robust with built-in QC checks in it. It should be so good that I don't need my institute to help me buy it. I want to stand in line and pay for it with my own paycheck. It should be so easy to use, right? So that's the system we want to be able to use. So next slide, please. So again, system should be good, cannot be inferior to microscope. The scanner has been tested, has been used by multiple pathologists. There are some scan failures, but there are steps in the production to do those corrections. And again, helping learn this, making good slides as you feed them into the scanner is also essential. Next slide. And it's fast, right? You cannot add time to it. If it's going to take pathologists 2 minutes, 3 minutes to review the image, it's painful, it's slow, it is not going to be an easy experience. Next slide. And it should be reliable, right? So the system must be 100% trustworthy and dependable. No excuses. It cannot simply fail. And if it does fail, there is an easy way to get it back online. It goes, the robustness and the reliability of the scanner, the system, is all important. And it works well if you have a good relationship with your vendor and your IT team. So the machines are maintained and they're available to be used in real time. Next slide. And easy to use. Again, I don't want to belabor this point, but this is critical, right? You're going to hear from Dr. Schumacher later. This should be a system that she trusts as a pathologist. This system should be good, that the IT and the engineers and the maintenance staff, the technologists are comfortable with. Next slide. So overall, some other considerations are, if you're going to have multiple slides, if it's a large practice, you will need to have an image management system to help take care of and store these images appropriately. You might also need accompanying reports. You might, as a consultant, produce a report which could be converted into a PDF forms. There might be other data, radiology, gross images that could be easily transmitted to the system. So again, the need for effective communication is going to be critical. Next slide. So the things that are important is, again, in a large scale model, you want to be able to connect multiple hospitals who are sending images, associated data into a consultation portal using HL7 middleware, using a dashboard, institutional administrative, which is able to assign pathologists for the right diagnosis for the right case, and be able to communicate, order stains, consult colleagues, and use AI. So this is the ideal state. So today we're going to describe a journey towards this ideal state. So next slide. So this is the solution that we are going to show to you today. Next slide. This is the Grundium microscope or the scanner, which is easy to get to. You have your own institutional login. You are able to connect it. In our practice, we've been using this for frozen sections. We are starting to use it for cytology. And today what we're going to demonstrate to you is how it's going to be used and is being used for consultation from a community hospital. So next slide. So the images are easy to scan. The system interface is very easy to use. You're able to go to an region of interest, look at the cellularity. This is an example of rapid on-site evaluation, or ROSE. The pathologist could be anywhere on the network. As long as they're connected to the network, they're able to log into the system and review the images. And at that point, they have complete control over the system. They're able to go up and down because the image has already been scanned. So next slide. So you can see in the next few images, this shows you the rapid live view. You can go back to the next slide. So again, these are some examples of the system. Next slide. Next slide. So this is the interface where Dr. Schumacher is at Worcester. The slides have been scanned there, and she sends me a link or an email to go into the archive, look at the images. In fact, she just sent me a kidney consult recently, which I have to review. Next slide. I can go into the system. I can now pull up the whole slide image, and I'm able to go up and down, move the image around, go to higher magnifications. Next slide. And I can also I'm able to connect to as many scanners as there are in the system. And I can have access to the entire archive as long as I have a role and I'm allowed to gain access to those images. So it's super easy for me as a consultant to go into the system. I could be anywhere in the world as long as I am in a HIPAA compliant connection and I have role and permission to review those images. I simply go in, look at the image, and then offer my consult to Dr. Schumacher. Next slide. And next slide. So these are some examples of the consult cases. You can even look at immunostains when they become available. And next slide. So as long as the images are scanned, I can go to higher magnification, I can zoom up and down, I can move around, change objectives. So as a consultant, I have complete control over the system. The image quality is of diagnostic quality, and the speed and ease of access is very, very good. Next slide. So take-home messages from my perspective are digital pathology enables us to provide scalable, efficient, and global consultation workflows. We are implementing this for a global consultation as well. So again, it addresses all the pain points that I discussed with you in terms of turnaround time, in terms of coordination, in terms of missing slides, lost slides, and so on. Really, the next step now, which we're building, is to take this scanner and connect it to a consultation portal and be able to still use the enriched interface that the scanning software has already built into it. So it really, the next level is the integration with different EMRs, HL7, and really get a true digital workflow. So when properly implemented, integrated consult workflows will serve not only as a diagnostic accelerators, but also a platform for better return on investment for pathology departments. Because you can imagine if you have 6 hospitals which are 90 minutes away and you don't have to send pathologists to every hospital every time, especially for those complicated consults, you can create a consultation network where the pathologists who are already there in the smaller hospitals or are traveling there, they have access to all the subspecialists within minutes, not days or weeks. So with this, I'm going to hand it over to our next speaker, Scott Hammond. Scott, take it away.
Thank you, Dr. Parwani. I really appreciate that. And thank you to Grendium for having me. I really appreciate the invite, and I appreciate sharing the presentation with Dr. Parwani, my boss, and Dr. Schumacher, who I work closely with. Just to recap, my name is Scott Hammond, Senior Systems Consultant here in the DigPath division at OSU under the leadership of Dr. Parwani. I'm lucky to say Dr. Parwani is my boss. I've been in DigPath for almost 20 years. I have a few roles in DigPath. I manage our research scan lab. I'm a study coordinator for DigPath-related projects. I manage and validate many of our DigPath platforms, and also I assist our community hospital partners in establishing their DigPath programs, which is why I was asked to speak today, and that's what we'll dive into. Next slide, please. Okay, the first step in establishing a digital pathology program at your site is to identify the key stakeholders. And as this slide demonstrates, we've broken that into the 3 prongs of people that should be in that conversation: administrators, IT, and your clinicians and lab staff. These are the 3 teams that make this initiative happen, and without one of them, you're not going to have a successful adoption. All 3 pieces play a crucial role in the pipeline, from going to thinking about going digital to taking it live. Next slide, please. So the first step is admin. They're the genesis of the initiative. They're the decision makers and the ones that charter, identify key team members, and launch the project. They're the people that have the idea of, we want to go digital, we need to go digital. This is an official initiative of our hospital site, what have you. So my role at OSU is I connect with these community sites, like Worcester, for example, and I meet with the admin team first, and I lay out what I'm about to with them. Like, this is how this works, A, B, and C, and I'm with them every step of the way to go from starting the project to going live with it. Next slide, please. IT. So they play a vital role in this initiative by integrating the device into the hospital environment. From the start, IT will physically take the device. And I'm using the word device. We're talking about Grendium here, but this process could be used for all types of DigPath projects. IT will take the device and they will perform a security assessment. That is to ensure the integrity of the network and protection of patient data. The assessment is typically a survey, and the IT team will work directly with the vendor on that. IT will typically have some recommendations for maintaining security. It could be credentialed login, which Grendium has, single sign-on, or 2-factor authentication. Those are typical recommendations. Assigning a static IP address is essential. This ensures that every time the device is engaged, it's accessible via the hospital network and online when applicable. So, for example, a frozen, where time is the essence, you want to make sure that the Grendium or the device is online and accessible when you need it. Now, if you choose to integrate the device into your IMS, understand that this is a large undertaking and will require a decent amount of IT effort and some engagement with the device and IMS vendors. Next slide, please. Thank you. Okay, what is the vision of your digital initiative? That's an important upfront question. Is IMS or LIS integration a part of this division? If so, that might inform the type of device you choose for your program. Harmony across platforms will lead to successful adoption. So right now, we're in the process of validating the Path Presenter platform with Grundium for consults between OSU and Worcester, that pipeline that Dr. Parwani laid out in his presentation. We'll be launching that initiative soon. We're very excited about that, and we appreciate Grundium's help in launching that initiative. Next slide, please. Okay, so we've done admin, IT, and the other prong is the pathology team, the clinician team, the lab team. They perform the lion's share of the integration tasks. The tasks include identifying and demoing devices and reporting their thoughts back to admin. This is important because these are the people that will be utilizing the devices day to day, and different devices have different strengths based on the needs of each site. Choosing a physical location for the device. We know lab space is a premium. Are there active network ports in this area? These are little things to consider. Validation and training. So let's touch on the validation piece for a second. That's a large effort by the pathology team. For your lab cap documentation, you'll want to complete a validation consisting of a glass and digital read of an anonymized slide set by a pathologist, followed by a review of each answer sheet, the digital answers and the corresponding glass answers, by a second separate pathologist for concordance. And just FYI, for clinical use, the cap threshold for successful concordance is 87%. So that's the device validation. That would be followed by a user validation. This would be a record of each user, pathologist, successfully reading digitally from the device. And you could use a subset of the device validation for your user validation. And so the final piece in that would be the lab staff training and the workflow integration. And it's essential this piece runs smoothly, as the lab staff will be the ones physically utilizing the device, and successful adoption depends on whether the lab staff's relationship with the device and the workflow is successful. Are they comfortable using it along with their other duties? This is the time where we iron out any potential issues with the integration before going live. There will be issues. These little things come up, technical issues. You want to do this before you go live for successful adoption. Next slide, please. Okay, this is my final slide. So finally, there's a few things you want to consider as you launch your initiative, and you want to think about these things at the start, okay? What does your budget look like for this initiative? Because there are going to be other costs besides the device, like a Grundium, for example. Does your budget allow for any potential additional needs, like computer upgrade, network upgrade, some high resolution monitors, clinical grade monitors? Does it account for the annual service contract pricing for these devices? Do you have the staffing capacity for this initiative when you go live? Do you have the people that actually operate these? Have you identified the team members that day to day will operate these devices when you go live? These are some things to think about from the offset, so you have a smooth adoption. That's the conclusion for me. I really appreciate, again, being invited. I'm really happy to talk about this. This is a topic that I'm very passionate about, and I believe we're taking questions at the end, and I'm happy to answer anything that I can. Thank you so much for having me.
Hi there. I'm Melinda Schumacher, and what I want to talk to you about today is our community pathology group's experience of implementation of digital pathology and how it helps us increase our efficiency, mainly through the use of interdepartmental consultation, which helps to improve our turnaround time. So in addition to shortening the time from production of the glass slides to our rendering of the final diagnosis, digital pathology helps us to provide diagnostic interpretations on par with the specialist pathologists at the main university hospital through our sharing of cases with them. That supports our individual ongoing learning and professional development. And for me personally, that makes the job a lot more fun and interesting, continuous learning and ability to improve skills. Next slide. So there are a variety of goals and desired improvements through implementation of digital pathology, these have been already mentioned a little bit by Dr. Parwani and Scott, but digital pathology gives us the ability to work remotely. So we can work from home or any place where we have adequate computer support. And that decreases our need to travel. And some of us travel 90 minutes up to a couple hours in order to cover some outlying hospitals. And remote capacity or remote capability also gives us the option to reach out to hospitals further afield and provide, excellent university academic quality pathology work. Improved turnaround time and improved diagnostic accuracy all work together to increase pathologists and just overall system efficiency of the healthcare system, as we're able to provide accurate diagnoses more quickly. The clinicians can consider their therapeutic regimen, and patients are informed of their diagnosis and the implications more quickly. They're not waiting for a delayed diagnosis because of having to ship slides and handle them. And this ultimately leads to improved patient care and improved satisfaction, not just satisfaction for the patient, but also the clinician and the pathologist as well, that we're doing our job well. Next slide. So as I mentioned, remote capability means that we can work from home or any location that provides adequate computer support. And the case assignment also can be variable and transferred easily, depending on pathologist availability. Sometimes there's unexpected emergencies, there's sick time, or there's unequal workloads at the different sites we cover. And without any additional investment, no courier needed, no driving for the pathologists involved, we can just reassign cases just by a few clicks. Next slide. So improved turnaround time, especially for cases which require additional, second opinion or guidance by a specialist pathologist, is probably the biggest impact that I experience with digital pathology. So the slides are instantly available. Their images are instantly available once the slides have been scanned, and oftentimes that's faster. Usually, especially being at the outlying clinical community sites, it's usually faster than waiting for the slides to be delivered. And another advantage is that multiple reviewers can look at the slides simultaneously, We don't have to ship the slides to one person and then the next person and the next person. The images are available to everyone at the same time. Next slide. So improved diagnostic accuracy. As I said, we can provide diagnoses that are on par with a specialist pathologist. So even things we haven't seen before, don't have much experience with, through the specialist pathologist guidance, we can work up the case efficiently. You know, which stains should we order? What are we looking for? And make sure we have the correct, most helpful, most accurate diagnosis. And as I mentioned before, but I really like to emphasize it because it's so important to me, this all enhances ongoing learning and professional development of the pathologist, makes the job a lot more fun. Next slide. Digital pathology also helps with making, well, not only the pathologist, but the whole system more efficient. We can share the workload and we can balance it out with redistribution of cases in case. So we cover I think 8 sites, and we don't have a pathologist on site on site at every site. And some places we have 2 pathologists on site typically, or we have in the past. But we're working towards a more centralized setup so that the pathologists can, we'll have medical directors based at the outlying sites, the community hospitals, but we'll have a group of pathologists who now have been like the travelers or the rotators, you know, that have to move from hospital to hospital on different days. They can be all centrally located and just have their usual office to work from, not have to drive these long distances, and cases can be balanced between everyone so that not one pathologist gets slammed with an exceptionally heavy workload one day or one week or even just overall, because, you know, different sites have different volumes. And then another exciting aspect of digital pathology are potential AI options. Some of these are in development with, you know, Grandium, and others platforms may already have some of these ongoing or set up. But I'm looking forward to when we can use the digital microscope and the computerization to count mitoses, for example, in a 1 millimeter square field, or counting cell types, say eosinophils, how many eosinophils per high power field in the esophagus, or estimating the Ki-67 proliferative index. These are onerous tasks that I don't enjoy doing. I don't think anyone else really does. And it can also be helpful in estimating tumor volume, tumor percent, particularly in prostate cases. Next slide. So increased patient care and satisfaction is kind of the overarching goal of all aspects of medicine. Clinicians get accurate diagnoses more quickly and can quickly implement optimal therapeutic plans. And patients find out their diagnoses more quickly, the implications of that diagnosis, and can start treatment sooner. And I think I'm very aware of how much patients really suffer when they're waiting for the diagnosis. Is it benign or malignant? What's this going to mean for a change in my life? And by being able to give the most accurate diagnosis more quickly, we really help to support better patient care. And this greater system efficiency ought to promote greater satisfaction for both clinicians, their patients, and also for us as pathologists. It works, it helps everyone all around. Next slide. So additional advantages of digital pathology is it eliminates the risk of misplaced slides. As Dr. Parwani mentioned, you know, we never lose a case, but sometimes the slides can be mislocated for extended period of time. And, you know, we also don't have to wait for them slides to be shown around to multiple pathologists, you know, with the risk of getting lost at every step of transfer. They're all in place. The images are available for internal as well as external review, and it's my understanding we're working towards being able to consult with external experts, potentially throughout the world. We use digital pathology in order to present at tumor boards or other conferences with clinical pathologic correlation. And that's really cool because not only does it provide information to other physicians, keeps them a little bit updated in what pathology, what histology looks like. And I think it really presents the pathologists more prominently out in the medical world and with our colleagues at the hospital. And I think it promotes respect, and that's important. At OSU, we use digital pathology for presenting at interesting case conferences every week. And then consensus conferences are held by the specialist divisions, sometimes daily, sometimes weekly, but it allows everyone to see the slides all at the same time and discuss them together. That promotes, you know, learning experience and getting the right diagnosis. Educational purposes otherwise, teaching medical students, teaching residents. And then historical review of, you know, past specimens for research purposes or also for help in working at current cases. And what I really enjoyed recently was here at Worcester, I got a case with a liver core biopsy of a metastasis. The patient had a prior diagnosis of malignancy, and this was some sort of sarcoma. I think it was probably a liposarcoma. I don't remember for sure, but it was something that I see rarely. But rather than send the case out for an expert to look at it, I was able to read in the electronic medical record that the original tumor had been excised at Ohio State about 8 years ago. I was able to go into our OSU IHIS, look up the case, find the case, look up the images, they were there, review the histology, and be assured that the histology I was seeing in the current liver metastasis was the same as the original tumor. And so I could not be interrupted in my workup of the case. I mean, there was really no workup. It's just assessing the previous biopsy, are they histologically compatible? And I could sign the case out. So I wasn't interrupted. I wasn't delayed. I didn't have to wait a couple of days for archives to find those old slides, for the courier to bring them up to Worcester. And I didn't have to order a bunch of IHC stains and all the expenses associated with that. I could just read my slide, spend a few minutes hunting for the digital image at OSU, compare them, they're the same, and sign the case out directly as histologically compatible with the original tumor. So that I think that's one of the most, I don't know, just a very, very much promotes efficiency in the system. Next slide. So there are some things to be aware of, and Scott has touched on these when you are studying up digital pathology at your site. I mean, you have to have the budget, and so you need support from administration or whatever your budgetary sources to allow you to move forward and make the purchases and the costs of implementing digital pathology. You also need support from your IT department. They have to, you know, have the capacity to set up all the computer stuff, not my area of expertise, and they have to have the interest, you know, the interest and the willingness to work on it to help you out. You need adequate computer hardware, adequate memory, all that sort of stuff, and you also, I think it's important to be aware that when you're looking through your digital microscope on site, you know, through your local Ethernet, the images are fantastic and the download is almost instantaneous. It's really, really good, especially with the M40 from Grundium that we're using now. But with cloud transfer, the experience degrades a little bit, but it's still adequate. And I've used the M40 images when I've worked at Ohio State. A couple weeks ago, I was off service at Worcester Hospital, so I went into OSU to sign out some cases, and it worked just fine. I had no trouble doing some additional work from afar. So we also need availability of well-trained staff, histotechs or whoever your lab techs are that will do the scanning and keep track of things for you and enter all the data associated with the slide when they do the scanning. It's also very helpful to have a clear training plan for the end users, for other pathologists. Okay, this is something new. This is how you access the images. This is how you find it quickly, and just some upfront planning around that, just to make things go more smoothly and to keep others' goodwill and wanting to help you out. And then vendor support. So if you have trouble, you have someone to turn to, and they can help you get fixed up quickly. So I think, is that my last slide, or do I have another one? Oh, okay. Benefits of digital pathology implementation include remote access, leading to better centralization, or the capacity, the ability to centralize the work and not have people traveling such far distances on a daily basis, and not like going one place one day, another place the next day, and then having the slides, but if you order recut special stains, having those try to follow you. And sometimes it's difficult to get to have the slides be in the same place as the pathologist on subsequent days. Remote capacity means that we can offer our services to a wider location. We can grow our department. Remote capability also allows us to recruit other pathologists, because not only do people want to work at places that are innovative, that's a big plus, but also the comfort or the ease of working from home and not having to travel long distances. And so we can also recruit from a wider network, physical wider network. We can more evenly distribute the workload. And I found that since working with the digital images and consults with my colleagues in the community division, as well as at main campus, that we're developing a greater sense of camaraderie and collegiality, and that is also makes the job more enjoyable. So greater job satisfaction leads to better work overall. And is that my last slide? Okay, good. I'm done. Thank you for your attention.
Thank you so much again for joining us today. We are ready to begin the live Q&A, and it looks like we have a few questions from the audience. If you would like to submit a question, please do so in the chat located in the GoToWebinar control panel. The first question that we have is, for new implementations, how long does a typical IT security review take?
That's a Scott question.
Yeah, I can answer that. The survey in that process in of itself doesn't really take that long. Typically, the site IT will have something like a questionnaire already in place, and it's really just the vendor answering those questions. They'll be proactive in doing that, and there'll be a little back and forth. That process is maybe 2 or 3 weeks. It's just, the questionnaire will consist something of the effect is of what is this device doing? What are the security ramifications? What ports need to be open? What type of exposure would our network, expect to have by integrating this device? So that back and forth really isn't that long, but generally, it kind of depends on what the workload of the IT team of the site is. You know, do they have a large IT team, a little IT team? Do they have a lot of IT projects going on? In my experience, IT is usually juggling a lot of things, but that part of the process really isn't that long. But whatever the IT recommendations might be, that really just depends on what those might be. But the questionnaire security process is really not long, maybe 2 or 3 weeks. Mm-hmm.
And another question that we have, maybe for Scott as well, but anyone can answer. It's, which LIS did you implement to support digital pathology?
Here at OSU, we use Beaker.
Okay, and the next question is, the FDA does not approve consultation utilization of digital path. How is the result of the consultation reported in the medical record? Is there a disclaimer needed?
Yeah, so we typically, we have a language in there about how we did the consult, but we don't distinguish the two routinely because we do it interchangeably. Most of the pathologists are already signing out digitally. But if you used a remote site and there is a checkbox in the LIS that generates a text based on that. So, and all of the sign-ons on the system are determined by your IP and your location. So it's the system keeps track of it. But we don't have a disclaimer for every case, because in some cases I might look at 3 cases as a consult, but then I might be at a different site and looking at the remaining 3 cases. So we don't have a specific language for that in every report.
Thank you. And how has your pathology lab staff, histotechs and PAs taken to using these scanners? What was the learning curve like? And did you notice a significant difference in going from the single slide system to a 4-slide system?
Maybe Dr. Schumacher can answer that.
Yeah, well, here at Worcester, we have the manager or the main supervisor of the histology, who's very adept at technological stuff. And so he was just naturally very enthusiastic about getting involved with this. And I think any place you're working where the employees feel appreciated, respected, and well treated, that they'll be willing to learn something new. So I don't find that to be a real problem. You just have to find the right fit for the job. And I think there was a second part to that question.
M1 versus M4. Do they like M4 better?
I don't know that they have any. I have not gotten any feedback from them about that. I think the M4 is great for the pathologist. I find that the image quality is just fantastic. So that's why we're using the M40 all the time now.
But I also think the higher slide capacity is important, because you might have one frozen, you might have 2 or 3 recuts, and you can put all of them on the stage. So I used it in my office before we purchased it, and I used it for 2-3 weeks, and I found it very easy to use. And the ability to have not going back to load one slide at a time was definitely a big improvement.
Yeah, I agree.
And what was the primary driver in your decision to go with Grendium and Path Presenter as opposed to other technologies?
So from our perspective, we've tested a number of scanners over the years. Like Scott probably had one of the earliest frozen single slide scanner. So we still use other scanners in our system. It's really the preference of pathologists, the institute that they work at, because they're not directly financially related to our main academic hospital. So they're independent hospitals. They evaluate these products independently. They look to us for expertise and guidance. But my belief is that we should let the we should empower the end user and let them select the system they like. As long as it's compatible with our existing network, we encourage that. So the decision to go with any vendor, not just Path Presenter or Grundium or Philips or like, we're not here to promote any company. I think those decisions were made because of ease of use, the price point, and the compatibility with different types of image formats. And at the end, for me, the number one reason we select technology is the person who operates it and the person who reads the images from it. And if they both like it, then it's a no-brainer.
Wonderful.
Yeah,
go ahead.
For me personally, I have had some experience doing like frozen sections from afar on other scanners, and I just found we started out with the G40, Grundium 40, the single slide with the higher resolution. I just found the image to be so far superior, the experience to be just much, much less frustrating. And I was more confident in my diagnoses.
That's wonderful. And we are going to take one more question. I believe that Scott can answer this question. Does the individual pathologist validation require both microscope and digital review of the case, or just the digital review of the subset of the cases used in the system validation?
Yeah, thank you. And I think I'm going to answer this correctly. If the question is, can you use the ground truth, the original diagnosis, you'll want to have the reviewing pathologist re-diagnose glass, because you want to make sure the validation process, the environment is the same for digital and glass. In the validation process, the slides will be anonymized. So the pathologist will only have access to the amount of data that you're providing in the validation. So using the ground truth would be a apples to apples comparison. I hope I answered that sufficiently.
Yes, and actually, let's go ahead and take one more question. We're just a bit over, but not a huge deal. Why not just use a common high throughput scanner for all of your digital pathology needs, rather than having to learn multiple scanners from multiple vendors?
I think that's something we already do. We don't use just one scanner for everything. We have a separate scanner for which can do Z stacking, and we are testing it for cytology. We have a separate scanner that we're testing for, which has fluorescence, immunofluorescence capability. So one size does not fit all. So we've been able to, with the expertise of Scott and his team and pathologists who are out in the community, be able to fine-tune our requirements. We're able to find the right application and the right scanner and connect the two. So the small scanners are good because they don't require a big footprint. They're easy to carry. Dr. Schumacher can actually carry one in her bag and go to another office and then plug it in and start sending consults or doing consults. So I think that's the beauty of today's marketplace. We have so many different choices as end users and consumers. We need small scanners for these type of applications. We need scanners which can hold up to 1,000 slides for other applications. Scott, is that correct? I mean, anything else you want to add?
I think so. Just echoing what you said, and also, there really isn't like a one-size-fits-all scanner. You might have a high throughput scanner, but then, you have high throughput scanners that are built for speed and volume, but they may not do the best job at scanning things like cytology and heme slides that need like a more nuanced scan, Z stacking, for example. So there may not be a one-size-fits-all platform. And then also for frozens, you might, like a Grundium, select a live view, which a scanner like a Philips or Hamamatsu, the high throughput, high volume scanners don't have that capability. But it really depends on what you're trying to do.
What's also nice about the little Grundiums is, so say the pathologist is working remotely and you've got a frozen section or a rapid on site, evaluation, the tech can take the little Grundium upstairs with them, plug it in, and send us the slides after, just a short delay for the scanning of, a couple minutes maybe. And you don't have to you can move that instrument, you don't have to revalidate it. It's just very, very user-friendly, adaptable.
That's great.
Yeah.
And
It unlocks the pathologist from the microscope. You're not chained to your microscope anymore.
that sounds wonderful. And that is all the time that we have for today. Any questions not answered during our live Q&A today will receive an email response from our speakers and the Grundium team. We want to thank Grundium and our speakers today for making this program possible. We hope you found it beneficial to your understanding of how digital pathology tools can reduce turnaround times and optimize consult workflows. Please be on the lookout for an email with the on-demand link for this program. This will also be your chance to ask for any additional questions and ask for a copy of the slide deck. As always, check darkdaily.com and opt in to receive the latest news and program updates. But for today, we are signing off. We hope you all have a great day. Thank you all so much.
Thank you.